This is Nursing 517 final case study as composed by Group 5. We are all students at the University of Illinois at Chicago in the College of Nursing. Midwestern Hospital's emergency department previously mainly served upper and middle class patients. Over the past 10 years, there has been a change in the population of patients coming into the emergency department. This new population is primarily refugees and immigrants from Somalia and Syria. These patients generally have a higher poverty level. The employees of the ER are generally unfamiliar with the cultural needs of the patients. There are also language barriers, different religious practices, and unfamiliar food and nutritional needs. Due to these changes, there has been loss of financial income because the insurance supplied by the patients is non-existent. Most of them do not have primary care providers, and there has been an increased volume in the number of patients. This has affected staff morale because of a lack of resources and an overcrowding of patients. The lack of staff has also fed resentment and resistance towards this new patient population. As the ER was configured during these 10 years when the changes in population were taking place, it was not equipped to provide adequate care to this new patient group. There was low quality of care, partly due to lack of resources, as well as cultural unawareness by the staff in dealing with the new patient population. There were more complaints by the patients who were coming in who felt their needs were not being met, not just with the amount of time it took to get to be seen by a provider, but also the quality of care and understanding they were getting by the staff. This also led to staff members' complaints about the overcrowding and their inability to meet the needs of the patients coming into the ER. In order to facilitate change in the emergency department, we used the John Cotter change model. This model was created by Harvard business professor John P. Cotter. The Cotter method outlines 8 necessary success factors that lead to organizational change. Cotter emphasized that transformation is a process, not an event, and for a successful change to take place, all of the steps must go in a correct order. Skipping the steps might result in a negative process in successful transformation and failure to change.
In 1980, most of you won't remember this, Tom Peters wrote a book And it was the first major book that started saying customer, 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 based on empirical research about what made great companies over time. And by the mid-1980s, you were getting more and more literature on this. And by today, there's a ton. And what's interesting is even though a few of those airlines did come up in terms of their customer orientation, most have not. And if you go and look at most industries, we have made progress. There's no question since 1980. But as I travel around the world, it's amazing how many companies come to me and say, we need to change, and the CEO, just last week, one said to me, we've got to be more externally oriented on the customer. So for 26 years, we've had this blast of information about this, and we still have the problem. And that's what I want to talk about today, why things haven't changed as much as we would like. I want to hear one idea at a time. Believe it or not, you're going to raise your hand. I'll go out. You don't need microphones. I'll just broadcast everybody else what you're saying, one idea at a time, about whether they're going to make the big leap, because they need, trust me, lots of change, and win or lose, and specifically what you saw there. What are the hints that lead you to that conclusion? Now, this is awkward to get going with, but I've noticed a striking pattern as I've done things like this around the world, and that is, under these circumstances, great leaders raise their hands. The power of tradition is huge. And if you don't somehow get it ground into something like the culture, it is amazing how it can kind of slide back, and that's the last step in these stories. Urgency. Urgency. Let's move. Let's take it. There's some new stuff. Let's see if we can process it. If it's no good, boom. Let's move on. Let's move on. Let's move on. That's how those guys were making a huge leap.
The first step in the Cotter process is to create an urgency for change. This is due to the new patient population by letting everyone in the institution know that significant adjustment is needed if the hospital wants to meet the needs of the community. We also needed to address the need for additional resources for the emergency room by looking at census numbers, average acuity, nurse-to-patient ratios, the number of people leaving without being seen, patient satisfaction scores, staff satisfaction scores, and cost to lost patients to the hospital. All of these were issues which significantly affected the operation of the emergency department and needed to be changed. For both areas of change, the cultural as well as the fast track, a committee would have to be formed. It consisted of key players with the power to proceed with the project, people with expertise in healthcare, and credible leaders who can push for change. We also had to hear the interests of the committee members and the concerns and the recommendations towards the plans that we needed to install to change the way the emergency room operated. The first task of this committee that was formed was to create a vision for change. They will complete and synthesize their findings in regards to what the hospital will be doing to meet the cultural needs of a changing community. It will also consult with the key players and leadership team to see for the need of a fast track area to treat the low acuity patients in the ED. Once the committee had formulated its ideas, it had to communicate its vision to the entire staff about implementing the cultural changes as well as the fast track changes. This was done with meetings, poster presentations, visual aids, and online tutorial models, demonstrating what the committee had found and how these changes would be implemented. The next step in the Cotter process was to remove obstacles. Some of these were internal obstacles, and some of them were external obstacles. Others were physical obstacles. We needed to clarify and streamline the responsibilities regarding cultural competency. We had to find space to locate the fast track area. We had to communicate to people about their concerns regarding the changes and how they would be affected. All of these obstacles had to be confronted in order for the program to succeed. Part of the Cotter process is to create short-term wins. This boosts the confidence of those involved so that they can go to the next stage. Some of these short-term wins that we used in the ER was an in-service for all staff by webinar. This allowed nurse educators to interface with staff about the changes that were happening. We also started to have case managers and social workers to see the lower acuity patients in the normal area of the emergency department. They were able to help patients make follow-ups and establish primary care and sign them up for insurance. By having them already working before the official fast track area was open, people were able to see how it could work. Building on the change was very important so that people feel the process is moving forward. Regarding cultural competency, a community liaison was assigned from the institution to maintain relationships between the emergency department and the community it was serving. In regards to the fast track area, a bare bones fast track with limited hours was opened to show how the new idea could work. Caseworkers would see patients there, and they ran the area with nurse practitioners. This was able to further show how the fast track area could work, as well as see which areas we needed to streamline further. The last stage of the Cotter method is to anchor the change into the culture of the institution. Regarding the cultural competency component, that training was fully integrated for every new hire that came into the department. Every existing staff member had completed the cultural competency training and annually reviewed what the main points were. Regarding the fast track area, it was expanded to be during the hours with the highest census times, and more case managers were hired to help sign patients up for health insurance as well as primary care physicians. This is a summary of the cultural change outcomes which took place in the emergency department. All staff were in-serviced, both in person and using webinars regarding cultural competency. These were held by nurse educators and champions of change. The in-service information also included community liaisons. The champions of change were staff nurses who had attended specialized trainings. These individuals will be helpful in completing the staff training on days when an ED nurse educator was not available. Webinars were also created in collaboration with the nurse educators, ED physician staff, community liaisons, and technology services from the hospital. Both aspects of this intervention will require interdisciplinary collaboration. Health challenges can be positively impacted by interprofessional collaboration in education. Building on the change from the webinars and in-services will include increased cultural competencies for new refugee population from the training. With changing patient demographics, cultural competency training is imperative in making sure the staff are properly trained to care for these patients. Effective cultural competency training is associated with improved competency of healthcare workers and improved patient satisfaction. Regarding interpreter services, the goal has been met to bring it into the culture of the organization. Education about interpreter services, both electronic and in person, was offered by the hospital, and it was included in the in-service and the webinars. A common problem in emergency department is underutilization of interpreter services. In a study completed in North California, it was found that 56% of encounters with non-English speaking patients did not utilize interpreter services, but instead used untrained medical staff or family members. In 11% of instances, no interpreting services were used. By educating staff about services offered and making those services more accessible and easily used by staff, services should be more utilized by staff benefiting non-English speaking patients. Nurse managers, champions of change, and nurse educators will be available as resources for both physicians and nursing staff who have questions regarding interpreter services. This is very important because studies have shown that there is significantly higher risk of making errors of potential consequence when not using interpreters. Regarding better relationships with the community, by establishing contact with the community liaison, the emergency department leaders will be able to add accurate information to the cultural competency training. This will also help give the hospital a positive face in the community among the population. The nurse educators and nurse managers will meet with the community liaison several times during the year to build this relationship. This page is a summary of what was accomplished by the fast track implementation. A fast track department with limited hours was started at first from the hours of 3 to 11 and was staffed by emergency medicine nurse practitioners. This was the first small win for the department, as shown on Cotter Step 6. A few months later, it was continuing to grow and it was incorporated into the culture of the organization. They hired extra staff, and the hours were extended so that it was open during high patient population times. The fast track has been increasingly utilized in recent years and is now in 80% of emergency departments across the United States. It has increased patient satisfaction and decreased the number of patients who are leaving without being seen. Implementing the use of a fast track has the potential to decrease wait times, especially from patients who are using the ER in place of a consistent primary care provider. It has statistically significant positive impact in Press Ganey scores as well. It allows the ER to provide improved quality of care to these patients despite growing census and spatial constraints. This resulted in improved patient satisfaction, faster service, and expanded capacity of the department. By opening the fast track area, it has given providers better tools to care for the new patient population in the ER. The employees will feel more supported and less overwhelmed by the increased patient load. An article looking at turnover in ERs, nurses reported that their jobs were highly physically demanding, and almost all surveyed reporting that their units were often understaffed. By including the staff in these changes, they felt more empowered in their place of work. They were included in the changes at many points, from the first steps until the implementation. The caseworkers and social workers are there to help connect patients with primary care. This involves collaboration between emergency department leadership, case managers, hospital administration, and financial leadership. These people will be necessary in creating and supporting the positions in the emergency department. The caseworkers will continue to see patients as it evolves over the time. Part of the discharge process will be speaking with the case manager to establish a primary care provider. This will help patients who do not know where to go for regular care in the community. This will be particularly helpful for the refugee population who don't come in with a primary care provider. Regarding advocacy, the type required for the establishment of the Midwestern Emergency Care would include providing support and background information for navigating the new healthcare system while anticipating the needs of those clients who are traversing through the challenging new healthcare insurance options made available by the Affordable Care Act. There were no changes in our healthcare system until the Affordable Care Act was approved to take effect in 2010. The Affordable Care Act, also known as Obamacare, was made to help expand the insurance coverage and increase access to care. According to one study by French, Homer, Gummas, and Hickling, researchers had shown the ACA reduced the number of uninsured individuals through individual coverage provisions, health insurance exchanges, Medicaid expansion, availability of subsidies, and other policy changes. Even with the ACA, health disparities according to race and ethnicity, geography, and economy still persist. One main difference between insurance in this country and most other countries is privatized insurance versus universal health care. Universal health care provides access to all citizens regardless of health, income, or status. Instead of having many insurance companies, these countries have one system funded by the government and paid for by taxes. These other countries also include social programs to improve the lives of citizens, such as free child care, increased vacation time, extended maternity leave. These social programs directly affect the health of the population by eliminating health disparities and allowing individuals to lead happier, reduced stress lives. This notion that promoting the rights of citizens and reducing disparities improves health is shown in Blass et al.'s article in 2008. To improve healthcare in this country, it would be beneficial to create a structure that would be more accessible and affordable for all citizens. This means creating less private insurance companies or having more government regulation. Creating more social programs would be a huge part of the plan as well. In the documentary Unnatural Causes, in Sickness and in Wealth, chronic stress and social inequalities are shown as some of the reasons for the vast health gradient between those who have wealth and those who do not. By creating programs that would alleviate some stress of the average citizen, such as more vacation time and free child care, the overall health population could improve. One of the most significant challenges to political advocacy is the lack of trust in political systems, which often lead to apathy. As health professionals, we are not always sure of who to believe, and therefore we are not sure whether to believe what those in leadership are saying. Health professionals could possibly believe we are making progress in advocating, yet in reality be spinning our wheels because the system makes change difficult. Advocating for what we believe would be best for our patients and takes energy and funding in the political arenas where our voices would be legitimately heard. Oftentimes, facts are skewed or spun in a specific way meant to mislead or use the bait and switch tactic. The governing bodies tell us one thing to get us to support them, and then when they get into a position where they have the potential to advocate, they do something else. Therefore, it is important to become more knowledgeable to better understand the political process in order for nurses to advocate effectively. While the changes that took place in this emergency department are small relative to the issues in the past few slides, successfully demonstrating that this institution could make the necessary changes to meet the needs of a new clientele can give confidence to everyone in our community of what is possible when we come together and act collectively. Now that the emergency department has increased throughput and is more culturally sensitive to the needs of the new population, the next step is to bring the changes to the rest of the institution. The Cotter model was largely effective, as it successfully brought about two significant changes to the emergency department simultaneously, but some of the staff found it too corporate and impersonal. The combination of the Cotter model and the fish philosophy in the project for the rest of the hospital would be beneficial for the implementation in the institution. The Cotter method will help guide the institutional support mechanisms and structures for change, while the fish philosophy will help change the staff attitude towards service and care. It will benefit the institution with regards to structures and processes from Cotter's method, as well as the upbeat and positive attitude of staff from the fish philosophy. These will be useful for increasing satisfaction of both internal and external customers. thank you for taking the time to listen to how significant changes were brought about in our emergency department. We hope that the lessons we learned will help you implement future changes in the rest of the hospital.